I want to tell you about a patient of mine. Her name is Eleanor. Eleanor is 78 years old, and she came to see me, not by herself. She came with her daughter Susan, who sat beside her in my office, and who looked like someone who had not slept properly in several months. And Eleanor herself seemed different from the woman I had seen 18 months earlier at her last checkup. She was quieter. She answered questions slowly with a slight delay. That was new. She repeated herself twice in the first 10 minutes without seeming to notice. And at one point, she looked at her daughter and asked her something that she had asked her just 4 minutes before. Susan caught my eye, and the expression on her face was the expression I have seen in the faces of family members more times than I can count. A combination of fear and grief and exhaustion and a desperate hope. That someone is going to be able to explain what has happened to the person they love. I looked at Eleanor's chart before I came into the room, and I had noticed something that I wanted to explore carefully. In the 18 months since I last saw Eleanor, 3 new medications had been added to her prescription list by 3 different specialists, none of whom had a complete picture of everything else she was already taking. And I thought, before we talk about dementia, before we order a brain scan, before we refer to a neurologist, I want to look at these medications very carefully. I am Dr. Daniel Chen, and what happened with Eleanor is something I have seen more times than I care to count in adults over 65. Cognitive decline that appears suddenly or progresses rapidly, that terrifies families, and that points toward dementia. But that is being driven not by Alzheimer's disease, not by vascular damage, not by any irreversible neurodegenerative process, but by medications that were prescribed with the best intentions by doctors who did not have the full picture. And today I want to explain which medications carry this risk, why they affect the brain the way they do, and what every family of an older adult needs to know before accepting a dementia diagnosis without first ruling out what I'm about to describe. But first, let me tell you what happened with Eleanor when I looked at her 3 new medications. I found the following. She had been started on a bladder medication called oxybutynin for overactive bladder by her urologist. She had been started on a sleeping tablet containing diphenhydramine for insomnia by her primary care physician. And she had been prescribed a low-dose antidepressant and the triptyline for nerve pain by her pain specialist. 3 medications prescribed by 3 different doctors, each of whom knew about their own prescription, but none of whom knew about the other 2. And all 3, every single one of them, belong to a class of medications that I need to tell you about today, a class called anticholinergics. Let me explain what anticholinergic means and why it matters so profoundly for the aging brain. Acetylcholine is one of the most important neurotransmitters in the human brain. It is the chemical messenger that is most critical for memory formation, for attention, for learning, for cognitive processing, and for the precise coordination of conscious thought. When you try to remember a name, when you focus on a task, when you process new information, when you follow a conversation, acetylcholine is the neurotransmitter doing the work. Now here's what happens. With normal aging after 65, the neurons that produce acetylcholine gradually decline in number. The receptors that respond to acetylcholine become less sensitive, and the overall cholinergic tone of the brain, the baseline level of acetylcholine activity, decreases. This is a normal part of brain aging, and it is one of the reasons why memory and processing speed change somewhat with age, even in perfectly healthy older adults. Now, here is the problem. Anticholinergic medications that block the action of acetylcholine in the brain, are extremely common in the prescriptions of adults over 65. They include medications for bladder problems, for allergies, for sleep, for depression, for Parkinson's disease, for stomach problems, and for pain. And they are prescribed routinely, often without any discussion of what they do to the brain. When an anticholinergic medication is given to a younger adult with a fully functioning cholinergic system, the cognitive effects are often mild or temporary because the brain has enough cholinergic reserve to compensate for the blockade. But when an anticholinergic medication is given to an adult over 65 whose cholinergic system is already diminished, there is no reserve left to compensate. The blockade hits a system that is already running low, and the cognitive effects can be sudden, significant, and to anyone who does not know what to look for, indistinguishable from dementia. Eleanor was taking three anticholinergic medications at the same time, and the cognitive burden of all three together was overwhelming. A brain that was already experiencing the normal cholinergic decline of a 78-year-old woman. Now let me walk you to the 9 most common medications that carry this risk that I want every person over 65 and every family member of a person over 65 to know about. The first medication is oxybutynin, which is the bladder medication that Eleanor was taking. Oxybutynin is prescribed for overactive bladder, a condition that is extremely common in older adults. And it works by blocking muscarinic receptors in the bladder wall, reducing bladder spasms and the urgent need to urinate. But muscarinic receptors are the same receptors that acetylcholine acts on in the brain. And oxybutynin crosses the blood-brain barrier very readily, blocking those receptors in the brain, as well as in the bladder. Research has shown that oxybutynin has one of the highest anticholinergic burdens of any commonly prescribed medication in older adults. And it is specifically listed on the American Geriatric Society Beers criteria as a medication to avoid in adults over 65 because of its cognitive effects. There are alternative bladder medications, including mirabegron, that work through a different mechanism that does not cross the blood-brain barrier. If you or someone you love is taking oxybutynin and has noticed cognitive changes since starting it, please raise this with your doctor immediately. The second medication is tolterodine, another bladder medication in the same class as oxybutynin, also prescribed for overactive bladder, also an anticholinergic, also on the Beers criteria as potentially inappropriate for adults over 65, also associated with cognitive impairment in older adults, including in a 2015 study published in JAMA Internal Medicine that found a significantly increased risk of dementia associated with cumulative use of anticholinergic medications, including tolterodine in adults over 65. The third medication is diphenhydramine, the active ingredient in many over-the-counter sleep aids, including Benadryl, ZzzQuil, Tylenol PM, and Advil PM. As I discussed in detail in my previous video on sleep aids to avoid after 65, diphenhydramine is one of the most potent anticholinergic medications that older adults are exposed to. And it is available without a prescription, which gives most people the impression that it is completely safe. It is not safe for the aging brain. A landmark study published in JAMA Internal Medicine followed over 3,000 older adults for an average of 7 years and found that cumulative use of anticholinergic medications at the level equivalent to taking diphenhydramine daily for 3 or more years was associated with a significant increase in dementia risk, including Alzheimer's disease. Eleanor was taking this medication every night to help her sleep, not knowing what it was doing to her brain. The fourth medication is amitriptyline, a tricyclic antidepressant that is also prescribed for nerve pain, migraine prevention, and sleep. Amitriptyline has one of the highest anticholinergic profiles of any antidepressant available, and it was the third anticholinergic that Eleanor was taking simultaneously. Amitriptyline is explicitly listed on the Beers criteria as a medication to avoid in older adults, specifically because of its cognitive effects. There are alternative antidepressants with significantly lower anticholinergic profiles, including SSRIs such as sertraline and SNRIs such as duloxetine that can be used for both depression and nerve pain without the same cognitive burden. The fifth medication is paroxetine, which, unlike most other SSRIs, has significant anticholinergic properties. Despite belonging to a class that is generally considered cognitively safer than tricyclic antidepressants, paroxetine is the most anticholinergic of the SSRI antidepressants. And in older adults, it can produce cognitive effects that are meaningfully different from the other members of the same drug class. If you are taking paroxetine and you have noticed any cognitive changes since starting it, a conversation with your doctor about switching to a different SSRI with a lower anticholinergic profile, such as sertraline or escitalopram, is worth having. The sixth medication is promethazine, an antihistamine that is prescribed for nausea, vomiting, motion sickness, and sometimes for sleep. Promethazine, like diphenhydramine, is a first-generation antihistamine that crosses the blood-brain barrier readily and has significant anticholinergic properties. It is another medication that is on the Beers criteria list as potentially inappropriate for adults over 65, and that in older adults can produce significant and sometimes rapid cognitive impairment. The seventh medication is hydroxyzine, an antihistamine and anti-anxiety medication prescribed for anxiety, allergic reactions, and sometimes for sleep. Hydroxyzine is another first-generation antihistamine with significant anticholinergic properties that is used more commonly than many doctors realize in older adults as a supposedly safer alternative to benzodiazepine medications for anxiety or sleep. But its anticholinergic burden makes it far from safe for the aging brain of an adult over 65. The eighth medication is chlorpheniramine, a common antihistamine found in many over-the-counter cold and allergy medications, including products that are specifically marketed as nighttime cold remedies. Chlorpheniramine is another first-generation antihistamine with significant anticholinergic properties and significant cognitive risk in older adults. The problem with chlorpheniramine is that it is hidden inside combination products that older adults take for entirely separate reasons: a cold remedy, a nighttime pain reliever, a sinus medication, without realizing that they are taking an anticholinergic medication that is adding to the cumulative burden on their aging cholinergic system. The ninth medication is meclizine, prescribed for dizziness, vertigo, and motion sickness. Meclizine is widely used in older adults because dizziness and vertigo are common in this age group, and it does provide symptom relief, but it is another anticholinergic that crosses the blood-brain barrier. And in older adults, particularly those already taking other medications with anticholinergic properties, can contribute to a cumulative cognitive burden that produces confusion, memory impairment, and the kind of rapid cognitive decline that Eleanor experienced. Now, let me explain something called anticholinergic burden, because this concept is critical to understanding what happened to Eleanor and what may be happening to older adults taking multiple medications right now. Anticholinergic burden is the cumulative effect of all anticholinergic medications a person is taking added together. Each anticholinergic medication has a score on scales like the Anticholinergic Cognitive Burden Scale or the Anticholinergic Risk Scale that reflects how strongly it blocks acetylcholine when multiple anticholinergic medications are taken simultaneously. Their burdens do not simply add up, they compound. The total cognitive effect of 3 moderate anticholinergics taken together is far greater than 3 times the effect of any one of them taken alone. Eleanor was taking oxybutynin, diphenhydramine, and amitriptyline, all 3 of which have high individual anticholinergic scores. Together, the cumulative burden on her brain was enormous, and the cognitive effect was what her daughter described as her mother disappearing in front of her eyes. Over 18 months, now I want to tell you what happened when I recognized this. I called Eleanor's 3 prescribing doctors and I explained the anticholinergic burden picture that I was seeing. We agreed to a plan to systematically reduce and, where possible, replace the anticholinergic medications one by one. Over a period of 8 weeks, oxybutynin was replaced with mirabegron, a bladder medication with no anticholinergic properties. Diphenhydramine was stopped, and Eleanor was referred for CBT-1, cognitive behavioral therapy for insomnia, which I discussed in my sleep aid video, as the most evidence-based approach for chronic insomnia in older adults. And amitriptyline was gradually reduced and replaced with a low dose of duloxetine for her nerve pain, which has a significantly lower anticholinergic profile. 3 months later, Eleanor came back to see me, again with Susan. And Susan was different. Her eyes were different. There was something in them that had not been there 3 months earlier, something close to relief. And Eleanor herself was different. She was present in the way she had been before those 18 months of gradual, quiet disappearance. She answered my questions without delay. She remembered what we had discussed at our last appointment. She did not repeat herself. Her mini mental state examination score had improved from 22 out of 30 to 26 out of 30 in 3 months, just from changing her medications. Susan held her mother's hand across the desk and looked at me and said, "We thought we were losing her." And I want to say something clearly, because I know that story will give hope to some people watching this who are in Susan's position. I also want to be honest. Not every case of cognitive decline in an older adult is medication related. Alzheimer's disease is real, vascular dementia is real, and other neurodegenerative conditions are genuinely progressive and cannot be reversed by changing medications. But medication-related cognitive impairment is also real. It is common, it is underdiagnosed, and it is reversible when identified early enough. And the tragedy is that it is so often missed because the symptoms look identical to true dementia, because multiple prescribing doctors are not communicating with each other, and because the older adult and their family do not know what questions to ask. The most important thing you can do, if someone you love over 65 shows signs of rapid cognitive decline, is to bring a complete medication list to every appointment, every single medication, including over-the-counter products, including sleep aids, allergy medications, cold remedies, and anything else they take regularly. And ask their doctor specifically, what is the anticholinergic burden of this complete list? And could any of these medications be contributing to the cognitive changes we are seeing? Those words, anticholinergic burden, will be understood immediately by any doctor who knows what to look for. And if they are not immediately understood, that itself is information worth noting. You can also ask for a referral to a geriatrician, a specialist in the medical care of older adults, who will be familiar with the Beers criteria, with anticholinergic burden scales, and with the process of systematic medication review that can identify and address this kind of problem. Let me bring everything together now. 9 medications commonly prescribed to adults over 65 that carry significant anticholinergic risk and that, in combination, can produce cognitive decline that is indistinguishable from dementia. Oxybutynin and tolterodine for overactive bladder, diphenhydramine in over-the-counter sleep aids and allergy products, amitriptyline for depression, nerve pain, or sleep, paroxetine, the most anticholinergic of the SSRIs, promethazine for nausea and vomiting, hydroxyzine for anxiety and sleep, chlorpheniramine hidden in cold and allergy products, and meclizine for dizziness and vertigo. Every one of these medications blocks acetylcholine in a brain that is already producing less of it after 65. And when multiple anticholinergic medications are taken together, the cumulative burden can produce rapid and devastating apparent cognitive decline in an older adult who was managing fine before the medications were added. Eleanor's story does not end with her disappearing into a diagnosis that nobody questioned. It ends with her daughter holding her hand in my office and the light back in Eleanor's eyes because someone finally looked at the complete picture and asked the right question. I am Dr. Daniel Chen. If this video gives even one family the information they need to ask that question for someone they love, then it will have been the most important video I have ever made. Please share it with every family that has a loved one over 65 on multiple medications who has been showing signs of cognitive decline before accepting a dementia diagnosis. Without exploring this first, subscribe to this channel for weekly videos made with genuine care for older adults and the families who love them. And leave me a comment below. Tell me if you recognize any of these medications in the prescription list of someone you love. I read every single comment, and this one I will read with particular care. Take care of yourself and take care of the people you love. Their minds deserve to be protected.